although that's where I went to school rather than where I'm currently employed. Still, it did create some problems during my time as chair at Ohio State. Had to keep a low profile on. No, they all knew. They all knew I had questionable loyalties. But in any event, both are great institutions. Next slide, please. So presentation will be recorded as always, and chat Q&A button for questions. Next slide, please. So as you can see, Joel Gagnier will be presenting on musculoskeletal COVID, which we'll get into in a little bit more. December 12th, malnutrition, COVID-19 outcomes. Next week, Jana Ponce, and the week after that, TBD, although rumor has it that Ken Gersig may be involved in presentation. Then we take some time off, December 26th and the 2nd. Then we'll hear about metformin associated with less severe COVID-19, which is actually very interesting. Somehow it seemed like a plausible conjecture, but that's great that there's data on that, and N3C analyses and how they informed a phase 3 trial by Justin Rees and Carolyn Bramante. And then we have January 23rd, collaborative cohort of cohorts, C4R, that's a cool name, for collaborative cohort of cohorts for COVID-19 by Elizabeth Alsner. Next slide, please. So I think this hasn't been updated in the last couple of weeks, so we still have 6.5 million COVID cases. Next slide, please. And so musculoskeletal associated post-acute sequelae of SARS-CoV-2, and Joel Gagnier is clinical epidemiologist and associate professor at the University of Michigan. So I think with that, Joel, you share your slides and be interested to hear what you have to say.
Perfect. Thanks very much for the introduction. Here we go. I'm sharing slides. While I'm still adjunct professor at University of Michigan, I have now officially transitioned over to a Canadian university. So I'm now at, now they can't confuse the two Joels from Michigan, Dr. Seltz. So I'm at Western University, formerly it used to be called the University of Western Ontario. Western University, I'm in the Department of Epidemiology and Biostats there, cross-pointed in surgery. Most of my research is on cross-pointed in surgery, not because I'm a surgeon, though I am trained in primary care medicine. I do research in musculoskeletal conditions. So I am the lead of the musculoskeletal domain for N3C, and we've been, of course, interested, as many people are, in post-acute sequelae of SARS-CoV-2, PASC, long COVID, chronic COVID. There's a few synonyms. Though there is some lack of consistency of terminology out there. So we're quite interested in what's happening in after acute infection, particularly with respect to musculoskeletal symptoms. So we're involved in a few projects in this regard, and I have a variety of colleagues that I work with. Most of you know what post-acute sequelae of SARS-CoV-2 is, or PASC. By the way, much of this work is funded by the Recover Initiative through the NIH, of which University of Michigan is a site on. So these are persistent symptoms. A large proportion of people report these, as we know now, and many for lots and lots of months. So there's potentially a really large impact. One of the earlier decent systematic reviews and systematic meta-analysis that had been done on the topic showed a whole slew of symptoms from general fatigue, muscle weakness, myalgia, arthralgia, depression, dysphoria, and a whole series of other symptoms in varying degrees of proportions. And we started to know more and more about this as the evidence gets more rigorous. Most studies have found that myalgias and arthralgias are common, really common, often in the top 5 of symptom categories. And either they're new symptoms or they're existing symptoms that have gotten worse. We know that the risk capacity is higher in folks with greater severity of the acute infection, as well as certain types of procedural interventions that are used with folks with acute COVID. Those with specific symptoms in the acute period seem to have a higher incidence of PASC, those with fatigue, headache, dyspnea, hoarse voice, and arthralgia, those who are older and those who have more comorbidities. And it looks like post-acute physical rehab actually prevents some of these symptoms, as it would for other types of conditions, as you can imagine. So we published a paper in the Journal of Bone and Joint Sciences Reviews. Basically, the idea was this paper is not a systematic review, though we do review a lot of evidence in the area right up till about 8 months ago. Took a while for the paper to get published, just because of the delays in the editorial processes. But we were finding, a whole bunch of evidence, though it's pretty disorganized still at the moment. So what we were trying to do is to inform the types of data that we were going to pull from our approved data use request with N3C to try to understand post-acute musculoskeletal symptoms and the overlap with psychosocial symptoms, etc. So this paper, together with Rachel Bergmans and Dan Claw from the University of Michigan, have a look, and this is where a lot of our initial hypotheses are being pulled from. And I'll tell you some follow-up studies. So it appears that, of course, that there's an interaction of pathophysiologic stresses with psychosocial stresses. We know that from a nice paper in JBJS as well, the main JBJS journal called Musculoskeletal Consequences of SARS-CoV-2 or COVID-19, that SARS-CoV-2 causes some inflammatory responses that, of course, affects the skeletal muscle and the bone and joint tissue, causing a variety of symptoms and of conditions. Further, there's deconditioning that happens because of respiratory symptoms effects, all of which have additional impact upon muscle function, endurance, and bone and joint tissues. Of course, compounding the pathophysiologic stresses are additional sustained disruptions that have happened over a period of time. As we all experience sleep disruption, changes in nutritional intake, decreased exercise, lack of interpersonal contact, there's evidence for all of this, which in turn has increasing effects on fatigue, anxiety, panic, depression. And these we know that pre-existing psychosocial phenomena, economic stresses, psychological or psychiatric diagnosis also appear to increase the risk of past symptoms, and particularly musculoskeletal symptoms, amongst other. So all of this together creates a very diverse interaction of factors leading to a variety of musculoskeletal symptoms, and we're trying to figure all of this out. Some of the challenges are, first of all, is just understanding the musculoskeletal sequelae. So are they new symptoms? Are they aggravated existing symptoms? What were some of the predictors, for example, comorbidities? Or was there a tendency towards folks to have chronic pain? So we're working on a variety of projects in this area. I'm going to describe a couple of them. And then the impact of specific psychosocial phenomenon on musculoskeletal sequelae. We don't know a whole lot about that. There's been focus in other areas, but not so much in the MSK system. And also, we're finding that the collection of data is not uniform. It's really difficult to do a systematic review and meta-analysis on this because there's different types of outcome measurement tools that are being used across this whole field. There's been some attempt at the development of core outcome sets, which is starting to be used. The World Health Organization, for example, and ICHOM have developed core outcome sets for COVID. And there is a suggested set of long COVID just recently published for long COVID or post-acute sequelae of SARS-CoV-2, basically a core outcome set. So a core outcome set are those outcomes that should routinely be collected if you're doing any type of study in this area. It doesn't mean it's the only thing that you collect, but they should always be collected, these particular types of outcomes. There's also challenges in designing interventional studies. we need to figure out some ways to lessen the impact of psychosocial stresses on musculoskeletal sequelae, those with PASC, and we're planning some projects in this area as well. And all of this will inform research outside of the post-pandemic issues that we're seeing. So what are we doing? We're doing a retrospective cohort study using N3C data. We're just refining the elements that we're going to do. We're going to pull. We're basically looking at musculoskeletal sequelae almost primarily, though also looking at the interaction with predictors, various demographic factors and pre-existing conditions, comorbidities, etc., in particular psychological diagnoses. We're also updating. So that review, as I said, that we published in JBJS Reviews is about the data is about 8 months old now. And of course, things are still progressing pretty rapidly in this post-COVID, the data that's being published in the area. So we're doing a systematic review and meta-analysis right now. I have a master's student who's working on that and a subset of this cohort study as a part of her master's project at Western in epidemiology. And then we're also planning on refining the core outcome set that has been developed specifically for studies looking at interventions for musculoskeletal symptoms in post-acute Sequelae of SARS-CoV-2. So this will be a set of outcome measures that will be recommended, particularly for musculoskeletal and some psychosocial symptoms as well. And that's all I have for you. Just a little update of what our thinking is in the area, kind of what the evidence is looking like. It's a little bit still in its infancy, and a few projects that we're working on. I'm happy to field any questions.
Okay, questions? So maybe talk to us a little bit more about what research studies you think would be new research studies would be valuable in this area. What do you think people should be looking at?
Yeah, and in particular, what we've seen is that obviously there's a complex interaction of biopsychosocial phenomena in there's that interplay that is resulting in a whole variety of symptoms. What our group is particularly interested in is what are the predictors of new or worsening musculoskeletal symptoms, as well as this subset of chronic pain patients with various types of musculoskeletal complaints, but also with psychosocial or quality of life, additional quality of life complaints that falls into the category of centralized pain or nociplastic pain. So that is, nociplastic pain. I was about to say nociceptive. It's easy to mix those terms up. But centralized pain, also called nociplastic pain, is that type of pain that there's no longer any external stimuli that's a noxious influence that's actually causing the signals of pain, but now it becomes a central nervous system phenomena. It's a vicious circle is happening that's supporting the pain signaling, and it looks like certain individuals are more susceptible to that than others, and there's also psychological phenomena that lead to an increased risk of that type of pain. So we think we're going to see and are seeing a fair bit of this in the post-acute sequelae world of SARS-CoV-2. So that is, I think, one of the key projects and one of the key pieces of work we'll be trying to figure out over the next 2 years.
What are your thoughts about how one might compare or get insight from other post-viral problems, Lyme disease, for instance, something along those lines?
Yeah, it's a really good point. Dan Claw, who's was the co-author on this recent paper, he's a colleague of mine, well-known rheumatologist, clinical trialist, and he basically sort of didn't coin the term, but mostly developed the science in the area of centralized pain And that work came from his understanding what was happening in surrounding Gulf War syndrome. But then the understanding of the Gulf War syndrome came from, like you said, like Lyme disease, or other types of viral infections that lead to an increased probability of having this type of centralized or chronic pain. And the symptoms can be overlapping across a variety of, if you want to call them diagnoses. For example, like certain types of temporomandibular pain, certain types of low back pain, or back pain, certain types of back pain in general. Also fibromyalgia, certain types of gastrointestinal conditions. So it looks like there's overlap between those, and then that viral infections lead to an increased proportion of folks with those conditions. Certain types of viral infections anyways. Yeah, so it's a really good point. Oh, and I should mention that Dr. Claw has a really nice paper that he's the senior author on. I should put the reference up, but in the journal, Pain Journal, on this exact concept about what we learned from prior investigations of viral infections and post-viral sequelae, and that will inform us about SARS past, pardon me.
So I mean, since you've been working in this area, obviously nobody knows, but do you have a sense as to whether past pain syndromes differ in a qualitative way, or from other post-viral or other chronic pain syndromes? Or do you see, I mean, obviously this is totally speculative, is whether post-viral SARS-CoV-2 is just a new path to essentially the same syndrome?
It looks like so far it's a new path, yes, to the same type of syndrome. Yeah, we're seeing that again and again. It may be it may be slightly more complex given given the national, international, regional responses to the pandemic, because of the various types of stressors that folks are under from all angles. We may be seeing more of it in more severe chronic pain conditions. But generally, the pattern looks really similar. Yeah.
Very interesting. Well, great talk. Very interesting. Any other questions? Let's see. I'm looking. I want to make sure I'm not missing anything. I'm looking at chat
You could feel free to email me at any time.
and Q&A. Okay, so I think that's what we have for today. Am I missing anything? Okay. Well, thanks. We'll give folks some time back, and very interesting work, and look forward to seeing the group next week. Thanks.
Awesome. Thanks, everybody.
Take care. Bye-bye.
Bye.